Thank you, Deepak, and hello everyone from Manchester in the UK. Thank you very much for joining us today to hear a little bit about what we're doing in Work Package 2 of the Conception Study. So I'm Rebecca Bromley. I'm a paediatric neuropsychologist, so I'm interested in how children's brains develop, and in particular, I'm interested in that within the context of medication exposures in pregnancy. I'm going to talk to you a little bit today about what we're trying to do to improve the longer term data collection that we do following medication exposures to understand about how child's health outcome and also their neurodevelopmental outcomes. So understanding child's health and neurodevelopment following exposure in the womb is really important. Understanding if a medication has the capability to alter the development of brain functioning in utero, which then leads the child to be more at risk of difficulties with intelligence or with social functioning later in life, is really, really important. Having this information helps people who are pregnant or who are planning a pregnancy, along with their doctors, to plan their treatments appropriately. But unfortunately, we know a lot less about these important outcomes than maybe what we should do. We have far fewer systems internationally investigating these outcomes at the moment than what we do for congenital anomaly or birth defect type outcomes. And I think this in part is historical, but it's also how we investigate this type of information. So for example, children's health and their brain development changes over time. We all see that in the children around us. So therefore, these outcomes aren't immediately present at birth, and therefore, ultimately, we need to follow up for longer until the child is older, and we may need different types of expertise. And this can be quite challenging in terms of time, but also expense. But there are significant consequences of us not having this information. More children would be exposed in the womb to potentially higher risk medications, the longer it takes us to learn about this. The flip of that also is that people of childbearing potential or who are pregnant maybe don't use their medications correctly because their healthcare professionals can't reassure them about the data that shows that they're safe. And so we feel that we need a renewed focus and improved system to investigate child health and neurodevelopmental outcomes. So there are lots of ways that we can collect data to look at this. We can have individual or groups of hospitals that recruit women from their clinics and follow their children up. We can also have pregnancy registers that might focus on a particular disease in a particular country. So for example, a pregnancy register for women with epilepsy. Or they could be pregnancy registers that are set up by pharmaceutical companies that, rather than being focused on a disease area or an illness area, are focused on a particular medicine. We also have adverse event reporting, which is the cornerstone of regulatory surveillance. And we also have the use of secondary data. So for example, routine hospital information and educational outcomes in the children, mum's pharmacy records that can all be linked together. And that's been very much developed by our colleagues in Work Package 1 of Conception. So what we wanted to do is to focus on what we could do to extend and improve neurodevelopment and child health follow-up in the studies that collect data already directly from women. And so these, for example, the pregnancy registers, the hospital cohorts, the teratology information services that already collect thousands of women around the world internationally who are pregnant and actually follow up, follow these women through their pregnancy to look at congenital anomaly outcomes and birth defect outcomes. And we want to be able to extend that follow-up to include the longer term child health and neurodevelopment. And so we started this piece of work by speaking to people who run these systems to find out what they need, so why they don't already do it and what the barriers are and what they would need to be able to extend that follow-up. So we can really sort of collaborate with these women to understand a little bit more than what we just do. And a very clear kind of message came back from the owners of these already kind of ongoing data collection systems, is that they needed it to be simple and they needed it to be inexpensive. And because they don't necessarily have lots of expertise in their group of collecting these outcomes, and they also don't have lots of financial resources available to them. So what we've been doing is sort of Really building on a little bit of work we did prior to conception and developing a standardized module of longer term follow-up for child health and development. So rather than these groups having to create these things themselves, we kind of design it for them, so that actually it can be implemented not only in their particular surveillance unit, but also in others. And the way that we're making it cost effective is that we're asking parents to help us understand their child's development. So rather than someone like me going out to review every single child, we're asking parents to complete developmental questionnaires that are used widely throughout the world. And we're asking them to report on their child's progress at important developmental time points. And we feel that this will allow us to rapidly identify medications which need further investigations. So a little bit of a signal generation system. So what would that look like in practice? Well, we take, for example, a group that is already running. So let's take, for example, the UK and Ireland Epilepsy and Pregnancy Register. Women are recruited during their pregnancy and they consent to giving information about their health and medications in pregnancy and also the outcome of their child at birth. And that's where their follow-up currently stops. But what we will do is help them develop the system that we're developing within conception and pop it into their kind of already running piece of work where women would consent to be part of that study for longer. And we would ask the women to tell us about the development and health of their child at 6 months, at 12 months, and so on, right the way through as their children get older. So what would this look like to the participants? Well, families will be recruited through the way that particular data collection system or pregnancy register recruited them. They would be told about the study right the way through and how they would report on their children, what our expectations are. And once they agree to participate, they would receive a text or an email, depending on their preference, linking them to the questionnaires. They would then complete the age-appropriate questionnaire, which contained lots of little tasks with their child, and they would enter the scores into the secure website. Now, it's interesting that standardization of data seems to be doing very well on the group map, and that's something that we're aiming to do. By helping develop this system from the kind of bottom up, we have an opportunity to standardize very early. And so what we're looking to do is to collaborate with a number of groups, and our two main pilots are here, the UK and Ireland Epilepsy and Pregnancy Register, as I've already mentioned, and also LARIB in the Netherlands. Now, these are two quite different systems, but by adding in this kind of same module or extension to ascertain information as children get older, it allows us to create a system where we can combine data across these different collaborators. And we are working with colleagues elsewhere in conception to develop a shared, safe data space to allow us to upload anonymous data. And where we think that this will be really, really important is for really rarely used medications where we don't have any idea about their risk or their safety in pregnancy. And also when new medications come along, it will help us speed up how fast we can get knowledge if we're able to pool anonymous data from across individual sources. So in summary, what we're working towards is an improved focus on child health and neurodevelopmental outcomes because we think they are incredibly important. Rather than starting from scratch, we want to work to extend already running data collection initiatives because there's a lot of experience there. We are utilising a cost-effective approach to screen, which will allow us to detect signals and will prompt rapid, confirmatory, detailed investigations to confirm or refute the signal that's generated. So that's just a little bit of a kind of a fast tour of a very large piece of work. And we're really interested to hear from you.